There's a number that could be sitting inside your medicine cabinet right now. It doesn't show up on any label. No pharmacist mentions it when they hand you your bag of prescriptions. But researchers at the University of Washington tracked it in over 3,000 people for 10 years, and what they found changed how doctors think about aging and memory. It's called anticholinergic burden, a name every family should know. And by the end of this video, you'll know exactly how to check yours in about 5 minutes, before your next doctor's appointment. I'm Dr. Roberto. I've spent years watching patients and their families walk into my office, convinced that a parent or spouse is simply getting older, slower to find words, forgetting where they parked, losing the thread of a conversation they were fully part of 5 minutes earlier. And sometimes that really is just aging. But sometimes it's something we can actually do something about. Today, I want to walk you through what that something is. Before we get into it, if you're new here, hit subscribe, because this is exactly the kind of research-backed topic I break down every week. Tap like on this one too. It's a small click, but it's what tells YouTube to put this in front of more families who actually need to hear it. And once you've watched the whole thing, drop a comment and tell me if this has ever come up for you or someone in your family. I read every comment and it shapes what I cover next. Okay, let's get into it. Let me tell you about a scenario I've seen play out more times than I can count, because I think it explains this better than any statistic could. An older adult starts taking an antihistamine every night just to help fall asleep faster. A few months later, they're prescribed something for an overactive bladder. Around the same time, an old prescription for nerve pain or sleep gets renewed automatically, the way prescriptions often do, without anyone stopping to ask whether it's still the best option. None of these 3 decisions happens in the same room, on the same day, or with the same doctor. Each one by itself looks completely ordinary. But 3, 6, 12 months later, family members start noticing something's different. Words come more slowly. Keys get lost more often. And almost everyone, including the doctors involved, chalks it up to age. That's the scenario I want to unpack today, because in a meaningful number of cases, age isn't the only thing going on. Let's start with the word itself, because it sounds more complicated than it is. Acetylcholine is a chemical messenger in your brain. It's one of the main tools your brain uses to lay down new memories, stay focused, and keep your muscles and organs working the way they should. As we get older, the brain naturally produces somewhat less of it and relies more heavily on what's left. A whole category of common medications, allergy pills, sleep aids, bladder medications, some antidepressants, some stomach medications, work partly by blocking that same chemical. That blocking effect is called an anticholinergic effect. It's not a flaw in the drug. In most of these medications, it's actually part of how they do their job. The antihistamine blocks a related receptor to calm an allergic reaction. The bladder medication blocks a receptor to calm an overactive muscle. The side effect on the brain is, in a sense, collateral. The drug can't always tell the difference between the receptor it's targeting and similar receptors sitting in your brain. One pill blocking a little bit of acetylcholine usually isn't a big deal. Your brain can absorb that. But here's the part almost nobody explains at the pharmacy counter. These effects add up. Take 3 or 4 different medications that each block acetylcholine a little, and the combined effect on your brain can be much larger than any single one alone. That combined stacked effect is what's called your anticholinergic burden. And it's more common than you'd think, because a lot of these medications don't look related to each other at all. One's for allergies, one's for sleep, one's for bladder control. On paper, they have nothing in common. In your brain, they're all doing the same thing at the same time. So, does this actually matter for memory? Let's look at the real research, because this is exactly where a lot of health content online gets sloppy, and I don't want to be one more source of noise. In 2015, a research team led by Dr. Shelley Gray at the University of Washington School of Pharmacy published a study in JAMA Internal Medicine that followed 3,434 adults aged 65 and older for about 10 years. None of them had dementia when the study began. The researchers used pharmacy records, not memory, not guesswork, to calculate exactly how much anticholinergic medication each person had actually been dispensed over that decade. What they found was a clear pattern. People with the highest cumulative anticholinergic exposure had a meaningfully higher risk of developing dementia than people with little or no exposure, and the risk rose the more of these medications someone was using and the longer they used them. Then in 2019, a much larger study by Carol Coupland and colleagues, also published in JAMA Internal Medicine, looked at nearly 59,000 people diagnosed with dementia and compared them to over 225,000 people without dementia. This study let researchers break the risk down by category of drug. They found the strongest associations with anticholinergic antidepressants, anticholinergic bladder medications, antipsychotic medications, and certain anti-epileptic and Parkinson's medications. Not every anticholinergic drug carried equal risk, but several major categories that a lot of older adults are prescribed showed a real, statistically significant association. Now, here's what I want to be very careful about, because this is where a lot of videos on this topic go wrong. An association is not proof that a specific pill causes dementia in a specific person. These are population-level studies. They can't tell us what would have happened to you individually if you'd taken a different medication instead. People who need these medications often have other health conditions that independently affect brain health. Researchers try to account for that statistically, but it's never perfect. What these studies do give us is a genuinely important signal. At a population level, cumulative anticholinergic use is linked to higher dementia risk, strongly enough that major medical organizations now take it seriously. That's not fear. That's just what good evidence looks like. So, which medications are we actually talking about? Let me give you real categories, not a scary countdown. First-generation antihistamines. This includes diphenhydramine, the active ingredient in classic Benadryl, and a lot of nighttime and PM-labeled sleep aids and cold medicines. It's sold over the counter, which makes people assume it's automatically gentle. Pharmacologically, it's actually one of the stronger anticholinergics on the market. Certain older antidepressants, called tricyclic antidepressants. Amitriptyline is the one most people have heard of. It's still prescribed today for nerve pain, migraine prevention, and sleep, in addition to depression, because it genuinely helps with all three. It also has meaningful anticholinergic activity. Bladder antimuscarinics, like oxybutynin, prescribed for overactive bladder and urinary urgency. These work by blocking a receptor that's closely tied to the same acetylcholine system involved in memory. Certain antipsychotic medications, including some prescribed off-label in older adults for agitation or sleep, rather than for the psychiatric conditions they were originally developed to treat. And one detail that surprises a lot of people. Among the newer antidepressants called SSRIs, most have very little anticholinergic activity, except paroxetine, which stands apart from other SSRIs in this specific way. That's actually why the American Geriatric Society's Beers criteria, which is basically the standard reference doctors and pharmacists use to identify medications that carry extra risk in older adults, flags paroxetine differently than most other SSRIs. One more thing worth understanding, because it explains why this hits older adults harder than younger ones. It isn't just that older brains have less acetylcholine to begin with. It's also that as we age, the liver and kidneys process medications more slowly. So drugs stick around in the body longer than they would in a younger person taking the exact same dose. And many of these medications are fat-soluble, meaning they can accumulate gradually in body tissue with repeated use rather than clearing out between doses. Put those three things together, less acetylcholine to spare, slower drug clearance, and gradual accumulation, and you can see why a medication that a 35-year-old tolerates without any noticeable effect can act very differently in someone who's 75. I want to pause here, because this is the actual point of this video, and it's not what you might expect. I am not telling you to stop any of these medications. Please don't do that on your own. Some of them, especially certain antidepressants and bladder medications, can cause real problems if you stop them abruptly. Some of them are genuinely the right choice for a person's situation, and the benefit outweighs the risk. My job here isn't to scare you off your prescriptions. It's to make sure you and your doctor are having a conversation that most people never get to have, simply because nobody adds up the total. Here's the thing about anticholinergic burden that makes it different from most other medication risks. It's almost never assessed as a whole. Your primary care doctor prescribes your blood pressure medication. A urologist prescribes your bladder medication. You picked up a sleep aid yourself at the pharmacy. Each of those decisions on its own might be completely reasonable. But unless someone sits down and looks at everything you're taking together, prescription, over-the-counter, and supplements, nobody ever calculates the combined anticholinergic load. And that's exactly the gap researchers and geriatric pharmacists have been trying to close. The good news is there are actual tools built for exactly this. It's called the Anticholinergic Cognitive Burden Scale, or ACB scale, and there are similar tools like it used in clinical practice. Pharmacists and geriatricians use these scales to score each medication a person takes and add up the total. You don't need to become a pharmacist to benefit from this. You just need to know it exists and ask for it. So let's make this practical. Here's exactly what I'd want you to do this week, whether it's for yourself or for a parent you're caring for. Step 1, write down every single thing you take. Not just prescriptions, include over-the-counter allergy pills, sleep aids, anything you take as needed, and any supplements. A lot of the risk hides specifically in the over-the-counter category because people don't think to mention those to their doctor at all. Step 2, bring that full list to your next appointment or call and ask for what's often called a medication review or a brown bag review, where you literally bring in the bottles. Ask directly, can we calculate my anticholinergic burden? And is there anything on this list we could safely simplify? Step 3. If your doctor or pharmacist identifies something with a high anticholinergic load, ask about alternatives. For allergies, newer antihistamines like loratadine or cetirizine cross into the brain much less than older ones like diphenhydramine. For bladder symptoms, there are non-anticholinergic options like mirabegron that work through a different pathway. For sleep, there are non-anticholinergic approaches worth discussing, including certain low-dose options and non-medication strategies like CBTI, a structured therapy specifically designed for insomnia. None of these swaps are automatic. They depend on your full health picture, which is exactly why this needs to be a conversation with your own doctor, not a decision made from a video. Step 4, and this one matters most. Never stop a medication abruptly on your own, especially antidepressants, anticonvulsants, or anything you've been on for months or years. Some of these require a slow, supervised taper. The goal here isn't to panic and quit everything today. The goal is a planned, informed conversation with the person who actually knows your full medical history. And here's the part I find genuinely hopeful, because most videos on this topic skip straight to the scary part and never land anywhere useful. When anticholinergic burden is identified and safely reduced under medical supervision, some of the cognitive symptoms it may be contributing to, the fog, the word-finding trouble, the attention slips, can improve. Not always, not for everyone, and not overnight. But it's one of the few contributors to cognitive decline in older adults that's potentially modifiable, which is exactly why researchers keep studying it and why it's worth 5 minutes of your time before your next appointment. If this helped you understand something you'd never had explained clearly before, that's exactly why I make these videos. And it would genuinely help me if you hit like on this one. It's the main way YouTube knows to show this kind of information to more people who need it. I'd also love to know in the comments, has anyone in your family ever had a medication review like the one I described today? Or is this the first time you're hearing this term at all? I read through the comments on these videos and it shapes what I cover next. And if you want more videos like this one, grounded in real published research, without the fear-mongering that honestly fills up too much of this space, subscribe, because I've got more of these breakdowns coming, including one soon on how to actually read and question a medication list like a geriatric specialist would. Take that list to your next appointment. It's a small conversation that, for some people, ends up mattering more than almost anything else discussed in that room. Before you go, I want to leave you with one more thought, because I think it gets lost in a lot of health content. This isn't about being afraid of medication. Every drug on that list exists because it solves a real problem for real people, and for a lot of patients, the benefit genuinely outweighs any risk to memory. The goal was never to make you distrust your prescriptions. The goal is to make sure the full picture actually gets looked at, together, in one place, by someone qualified to weigh it, instead of staying scattered across 3 different specialists who never compare notes. That's the whole idea behind a medication review. It's not a dramatic intervention, it's just someone finally adding up the total. If you found this useful, hit like before you go. Again, that's what tells YouTube to put this kind of research-backed content in front of more people who need it, instead of the fear-based version of this topic that tends to spread faster online. Drop a comment and let me know, are you going to ask for a full medication review at your next appointment, or have you already had one? I read every comment, and it genuinely shapes which topics I cover next. And if you want to keep learning how to actually read your own health information instead of just trusting a label, subscribe. I'll be back soon with the next one. I'm Dr. Roberto. Take care of that brain of yours. It's the only one you've got.